Hello, coders. Good morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome to another 3030 session with AMCI. First of all, coders, let me know, how do I sound? Am I audible? Are you able to hear me? Is the sound good? Okay. Let me know in the chat, coders. Come on. Good morning. All right, all right. Thank you for letting me know. So, welcome to another 3030 session. How are you all doing, coders? How are you all doing? I hope you all are doing great and feeling energized and also ready to dive into some exciting topics. So, today we will be working through the biopsies, debridement, excisions, and adjacent tissue transfers, all those integumentary topics. And we will be breaking down the guidelines and doing some practice exercise based on them as well. So get ready, coders. Grab your CPT manual, notes, and highlighters, and let's make this session interactive, fun, and super useful for your coding skills. I know you all are ready, so let's dive in. Let me begin by reading out the copyright CPT, copyright 2025, American Medical Association, all rights reserved. CPC is a registered trademark of AAPC, and the AAPC content found within this presentation is a copyright of AAPC. The keyword concept, FTR, Chun, AMCI Fab 7, AMCI ICD 10, Flip Tap, and MCG are the trademark of AMCI. The credentials CPC, CRC, COC, CPMA, CPB, CPPM, CPCO are owned by AAPC, and AMCI do not own right to these credentials. And the credentials CCA, CCS, CCS-P, RHIA, RHIT are owned by AHIMA, and AMCI do not own right to these credentials. Okay, so as I said, we will be reviewing the debridement, the biopsy, and the adjacent tissue transfer section today. And all these three, the biopsy, debridement, and ATT, falls under the integumentary section of the CPT manual. All right, coders. So, okay, I can see everyone in the chat. So let's begin with the debridement. Yes, it's an essential procedure in the wound management, and debridement means removing dead, infected, or non-viable tissues from the wound or ulcer. Now, but why do we do it? Why isn't debridement done? Here are a few important reasons why do it. Okay, so it is done to clean the wound and get rid of anything that might slow the healing process. It can be done to prevent or control infection. Yes, because no one wants the wound to get worse, right? And also to prepare the area for the next step, like in the case of a skin graft or a flap. And of course, to promote a proper healing by removing tissues that can't recover. Okay, so basically, think of it as giving the wound a fresh start so the body can do its job efficiently. Okay, so debridement procedures are coded using the CPT code series ranging from 11000 through 11047. Now let's break down the wound debridement codes, specifically the code CPT codes ranging from 11000 through 11008. So these codes are used when you are coding for an extensive eczematous or infected skin, or for a necrotizing soft tissue infection. So those words, those key words are very important. Now the code 11000 is used for the debridement of extensive eczematous or infected skin covering up to 10% of your body surface. And if the affected area is larger than 10 percentage, then we will use the code 11001, which is for each additional 10 percentage. So basically adding on as needed. Okay. Now, when we talk about the necrotizing soft tissue infection, debridement, things get much more specific. And the CPT codes are grouped based on the anatomic location. The code 11004 is used for a general is used for an external genitalia and perineum debridement, and this includes the skin, subcutaneous tissues, muscles, and fascia. So that's the level of debridement. It goes till skin, subcutaneous tissue, muscles, and fascia. And also 11005 is used for the abdominal wall debridement, and it also includes the fascia. And 11006, it is used for external genitalia, perineum, and abdominal wall with or without facial closure. Also, we have code 11008, which is used for removal of the prosthetic material or mesh from the abdominal wall for infection. So the key words here to remember are genitalia, perineum, abdominal wall, necrotic tissue, eczematous, and infection. So these will help you to pick up the right code quickly. Okay, so that was all about the code series ranging from 11000 through 11008. Okay, so someone is asking to make my screen larger. So coders, we are having two streams at the moment. One is for the mobile version and the other one is for the desktop version. So if you are joining us using a desktop or a PC, please move on to the stream which is dedicated for the desktop version. And if you're joining us with a mobile, you can move on to the mobile version of the stream. Okay. Okay, coders, I hope that will help. Okay, great. Awesome. So let's move on to the trauma scenario. So I'm going to talk about the debridement at open fracture or dislocation sites. So here we have code 11010, which is for debridement of skin and subcutaneous tissue, including the removal of any foreign material at the fracture or dislocation site. And 11011, that is for debridement that extends down to the muscle and fascia at the fracture or dislocation site. And finally, we have 11012, which is most extensive with the debridement that goes all the way to the bone at the fracture or dislocation site. Okay, so coders, you can see here also these codes are arranged or classified based on, once again, based on the depth of the debridement performed. And a quick coding checklist to remember. Yes, you have to know whether it's an open fracture or the site is open fracture or an open dislocation. Okay. And also note the depth of the tissue removed, as these codes are classified based on the depth. And add the surface area if multiple wounds are treated at the same depth. And also use a 59 modifier for separate wounds or sites. All right, great. So next, what are we having next? Yes, now that we have covered, okay, let me go back. Now that we have covered the trauma related debridements, let's move on to the other debridement codes. So these code sets ranges from 11042 through 11047. And these are your general wound debridement codes, while the ones which we just covered are more specific. Yes, specific to the trauma or the necrotic tissue or the infected cases or infection sites. Okay, now these are the general ones. Now these codes are, as you can see, again classified based on the depth of the debridement performed. So for a debridement done at the subcutaneous tissue level, you will code 11042. That is for debridement of subcutaneous tissue for the first 20 square centimeter or less. And 11045 is used for each additional 20 square centimeter. Okay. And next we have muscle and fascia debridement For that, you will use code 11043, which is used for debridement of muscles and or fascia, including skin, dermis, subcutaneous tissue for the first 20 square centimeter or less, and 11046 that is used for each additional 20 square centimeter. And then we have a bone debridement. So the codes used are 11044, that is for debridement of bone, including all the overlying tissues for the first 20 square centimeter or less, and 11047, that is for each additional 20 square centimeter reported with 11044. All right. Okay, now these are some of the guidelines of the debridement procedure. So debridement of a single wound coded for the deepest tissues removed. All right, and you have to check for the wound size, as all these codes are classified based on the depth of the debridement performed. Also, for the multiple tissues of the same depth, add the wound of the same depth. Use a 59 modifier for separate wounds or site, and use these codes when 11000 through 11012 is not applicable or do not apply. All right, coders. So very important guideline which you must remember is that if your provider treats wounds of the same depth, but on the different sides, you can add the total surface area together and code based on that combined area. And if the wounds are of different depth, then you don't combine them. Instead, you report them separately from each depth family. Okay. Okay. Now, here is an example, coders. This is an example for you all. We have 3 debridements performed here. Okay, and one is the debridement of the leg ulcer, subcutaneous tissue. That's a level of debridement, 15 square centimeter. And second debridement is performed at of the hand ulcer. Again, that's a subcutaneous tissue level, 15 square centimeter. And then we have a debridement of the shoulder ulcer, and the level is muscle, and it's of 10 square centimeter. All right. Now, what all codes can we pick up for this scenario? If you know, you can let us know in the chat. Okay, please let us know in the chat. And I will tell you how I'm going to solve it. As per the guidelines, we can add the areas of the same depth, right? So here we have a debridement of leg ulcer and hand ulcer performed at a subcutaneous tissue level. So they are of same depth. So I can add these two, and that will give you a total of 15 plus 15 square centimeter. That would be a 30 square centimeter in total. And for that 30 square centimeter, the code would be 11042. That is for a debridement of subcutaneous tissue, first 20 square centimeter or less. And also you have to use an additional or add-on code for the remaining 10 square centimeter. That would be 11045. And for the debridement of the shoulder ulcer till the muscle level, you will code 11043. And you should append a 59 modifier as well. All right. So I hope the guideline is clear. Okay, now let's move on to the next topic of the day. And we are going to talk about the biopsy procedures. Now, a biopsy is a medical procedure where the small sample of tissue is removed from the body for the diagnostic examination under a microscope. And the goal is to detect the disease, determine its type, and also to guide the treatment decision. And in dermatology, we commonly see 3 types of biopsy. There are several types of biopsy, but we are going to mainly focus on these 3 types of biopsy. One is tangential biopsy, the other is punch biopsy, and the third one is going to be incisional biopsy. Okay, and yes, let's start with the tangential biopsy. And the CPT codes used are 11102 and 11103. So this biopsy procedure uses scalpel, flexible blade, or curette to remove the tissue. And it removes the epidermis, sometimes the portion of the superficial dermis, but not a full thickness lesion. And the key here is it is a diagnostic procedure and not a therapeutic procedure. And we are taking just enough tissue to figure out what's going on under a microscope and not to remove the whole lesion. All right. So the common tangential techniques include the shave, scoop, sausurize, and curette. So they are also your keywords to know this is a tangential biopsy that is performed. Now, a quick tip that tangential biopsy is not an excision procedure, and if the provider is doing a therapeutic removal, you would use a code series that ranges from 11300 to 11313 instead. Okay, and these codes are, as I said, 11102, that's for a tangential biopsy of a single lesion, and 11103, which is used for an additional each additional lesions. All right, great. Okay, someone has asked how to get to the desktop views. Okay, team, someone in our team, can you please place the link for the desktop stream in the chat? That will be helpful. Okay, Codus. So now let's move on to the next topic, the punch biopsy. So next up is punch biopsy. The punch biopsy uses the punch tool to remove a full thickness cylindrical sample of the skin, and it includes your epidermis, dermis, and sometimes a bit of the subcutaneous tissue. Here also the purpose is diagnostic. We are taking a small cylinder of tissue from a lesion to examine it under the microscope. And the simple closure of the biopsy site is also included in these codes. So this covers any minor manipulation needed to close the wound neatly. All right. And the codes are 11104, which is for punch biopsy of a single lesion. Remember, it includes your simple closure if performed. And we have 11105 that is used for each additional lesion as well. And next, let's talk about the third type of biopsy, which is incisional biopsy. And the CPT codes used are 11106 and 11107. So unlike punch biopsy, incisional biopsy uses a scalpel to remove the full thickness wedge of the tissue, going down into the subcutaneous tissue. And this makes it ideal for the deeper lesion or the conditions like panniculitis. Now, the purpose of incisional biopsy is also diagnostic, okay, similar to the other two. And here also, a simple closure is usually performed, but it is not reported separately. That means simple closures are also included in these codes, and we won't report them separately. Now, if the provider is performing a complete lesion excision with margins, that will fall under the CPT 11400 through 11646. That is your excision area. Okay, and you should not code an incisional biopsy in such cases. Now, these are some of the biopsy guidelines. All right. So routine tissue collections during the excision or destruction or shave removal is not separately reportable as a biopsy. And a biopsy must be performed independently or be unrelated or distinct from the other procedures performed at the same time. So that means if a biopsy is performed as a part of an excision procedure, a destruction procedure, or a shave removal, you cannot code these codes separately. Okay. In such cases, the biopsy procedure is included to the excision or the surgical part, and you won't report biopsy separately. And the biopsy must be independent performed independently and unrelated or distinct from the other procedures if performed at the same time as well. Now, next guideline says that the biopsies of different lesion or different sites on the same date can be reported separately because they are not considered part of other procedures. And if a multiple biopsies are performed in the same encounter, you should code based on the complexity. So here is the hierarchy. So if we have all the three types of biopsies performed in the same session, like if we have an incisional biopsy, punch biopsy, and a tangential biopsy, all three performed at the same session, then you have to follow these hierarchy. Your incisional biopsy comes first, followed by the punch and tangential. So that is a very important coding tip code. Okay, so here are some coding rules for multiple biopsies. Okay, so if a multiple biopsies of the same type are done, use the primary code for the first biopsy and add-on code for the additional biopsy. And the primary lesion biopsy codes are the 11102, 11104, and 11106. Okay, and the add-on codes for additional biopsy are 11103, 11105, and 11107. So here is an example. When three incisional biopsies are performed, your code would be 11106, that is for your first lesion excision, and 11107 times 2, that is for your remaining two lesions. Okay, so in the next scenario, when multiple biopsy techniques are performed during the same encounter, you have to code for first, you have to code for the most complex primary lesion biopsy code first, and you have the hierarchy as I explained in the previous slide. Incisional biopsies comes first, followed by the punch biopsy, and then comes the tangential biopsy. And then use add-on codes for the additional lesions. Okay, so here is another example. If in a scenario where one incisional biopsy and one punch biopsies are performed, so as per the hierarchy, you should code for the incisional biopsy first. So the primary code for the incisional biopsy would be 11106, and then you have to code for the add-on code for the punch biopsy, and that would be 11105. And for a complete lesion excision with a margin, you can use the excision of the lesions code. That would be 11400 through 11646. All right. Okay, so I think my on clicks are not working properly here. Okay. Okay, cool. For some reason, my on clicks were not working. So next we are talking about the adjacent tissue transfers. Okay, and adjacent tissue transfer, otherwise known as ATT procedure. It's a surgical technique where the healthy tissues from the nearby area is moved to repair a defect, like a wound or a scar, often after an injury or a lesion removal. And the CPT codes which we use for ATT procedure are 14000 through 14302. And it covers your excision, including the lesion, also the repair by adjacent tissue transfer or rearrangement. Now, there are a few examples of the ATT procedures listed over here. It includes your Z-plasty, and you can see how a Z-plasty configuration looks like on the screen. It includes a W-plasty. This is another example. V or Y-plasty. It looks like a alphabet V or a Y. And we have a rotation flap. Then we have an advancement flap. Also a random island flap. That looks like this. Okay. So, coders, remember these are also the keywords for you so that you can identify a ATT procedure in a scenario. So, if you see such terms, make sure you code from the adjacent tissue transfer section. Okay. All right. So these are used when a reconstructive techniques are performed to close a defect, basically moving the tissue around to cover the wound. And these codes do not apply for a direct closure of the wounds. That is just a standard repair procedure and rearrangement that incidentally create a Z, W, or V or Y shape. Okay, so that is also important point to note. If a rearrangement that incidentally create such formations or such shape, you don't count them as an ATT procedure. And the undermining alone to close a wound does not qualify for an ATT procedure. Instead, you should code for a complex repair codes. Okay. And the excision procedure, the excision of lesions is not reported separately when done with ATT. That means the excision procedures are included to ATT procedure. All right. And also you have to have a good clarity regarding the term defect in ATT transfer, because this term, the defect, is something which you will see in the adjacent tissue transfer codes. So defects, there are two types. One is a primary defect. That's a wound created by the excision of a lesion. And we have also a secondary defect, and that is the area created by the flap design used to close a primary defect. Now, here is another important guideline. When selecting a CPT code, measure both the primary and secondary defects together. And if a skin graft is used to close secondary defect, report them separately as an additional procedure. Okay, so when a skin graft is used to close a secondary defect, you can report them additionally. Also, for a full thickness repair of special areas like lip or eyelid, use the respective anatomical subsections. Okay, Koda. So these are the ATT procedure CPT codes. As you can see, these codes are grouped by the area of the body and the size of the defect. So for the ATT procedures performed for trunk, you have code series 140000 through 14001. And if an ATT is performed on scalp, arms, legs, you have code 14020 through 14021. For the forehead, cheeks, chin, mouth, neck, axilla, genitalia, head, and or feet, you have code 14040 through 14041. For the eyelids, nose, ears, and or lips, you have code 14301 to 14302. So within each body area, the codes are further classified based on their defects. And there is also a flap code like a filleted finger or toe flap, that is 14350. So a quick tip: think of classification as body areas first and then defect size, then add on if needed. Now this will help you to pick the right code quickly and accurately. All right. So thank you for letting me know. Okay, Chorus. So I think we are done with the guidelines for the three sections, and it's time for us to do some practice scenarios. Are you all ready? All right, so let's go ahead and let's do the first one. Here is your question. Of the following answers, which best describe the procedure? Option A, 11104 times 2. Option B, 11106 times 1. 11107 times 1. Option C, 11106, 11107, 12031, 59 modifier. And option D, 11106 times 2. A 60-year-old male presents with two suspicious subcutaneous nodule, one on the right upper arm and one on the left forearm. The provider performs incisional biopsies on both lesions to obtain tissue for diagnostic histopathologic examination. The biopsy site on the right upper arm required a 2 centimeter layered closure due to the depth and tension of the wound, while the left forearm site was closed with a simple 1 centimeter single layer closure. Both tissue specimens were submitted to the pathology for analysis of the following answers, which best describe this procedure. Okay, so you have 2.5 minutes to code this one, coders, and your time begins right now. Once you're done, you can place the answers in the chat. Let's do it. All right, coders, I can see some of the answers are already in the chat. If you have completed, please go ahead. Please go ahead and place it in the chat. Okay, so I will start. I will start solving this scenario now. If you're still working on it, please continue. And once you're done, please place your answers in the chat. All right. Okay. I'm sorry, my OnClicks has some issues. Okay, so here we are having a diagnosis inventory. We're having a suspicious subcutaneous nodule, and the procedure inventory, we have an incisional biopsy performed, right? And let's look into the codes. So option A is coding for 11104 times 2, and that is for a punch biopsy of the skin. Now my question, did we have a punch biopsy? No, right? Cross-checking with my inventory list, the procedure inventory states that we had a incisional biopsy performed, not a punch biopsy. So that helps me eliminate option A. No, it's a wrong procedure. We had an incisional biopsy over here. Okay, now option D is coding for 11106. And 11106 is for an incisional biopsy of the skin single lesion. Now, this is a good code, but it is only coding for a single lesion, right? And as per our guidelines, it states that when two or more biopsies of the same lesion is performed, use the appropriate add-on codes here. First, we have to use the initial codes for the lesion, and then you have to use the add-on code for each additional biopsy. So in our scenario, we had two lesions, both were removed or both were biopsied using an incisional technique. So we, we can't code 11106 times 2. We have to use an add-on code here. That makes option D incorrect. You have to use add-on code, and the add-on code would be 11107, which is for each separate additional lesions. Okay, so option D is also wrong. There you go. Now we're left with option B and option C. So I can see most of you are split between the option B and C. Okay, so here we are going to have an aha moment. All right. So the guidelines over here, you can see I've highlighted the guideline. It states that although the closure is usually performed on incisional biopsy, simple closure is not separately reported. Yes, that means the simple closures are included in the biopsy procedure and we cannot code them separately. And if you read the scenario carefully, you can see that there was a 2 centimeter layer closure and a 1 centimeter single layer closure performed, right? So 1 centimeter single layer closure, that's a simple closure. It's also mentioned over there, closed with a simple 1 centimeter single layer closure. So you cannot report the simple repair performed in this scenario. But the first one, the first repair was done as a layered closure, and you all know that layered closure is an intermediate repair or intermediate closure. So intermediate closures are not included to these biopsy procedure, and yes, we can report the intermediate repairs separately. All right, how are you all doing, coders? So that is a reason why I would say option B is incorrect and option C would be the correct answer. It's coding for 11106, 11107, that is an add-on code, and 12031, which is the code for a repair intermediate of the wound of scalp, axilla, trunk, and or extremities of 2.5 centimeter or less. Okay, coders, let me know in the chat. How are you all feeling? Was that an aha moment? Okay, so remember, the simple repairs are included to the incisional biopsy, while the intermediate and complex repairs are not. Okay, great. So let's move on to the next one quickly. Here we go. Of the following answers, which best describe the procedure? Option A, 11106, C43.9. Option B, 11106, 11104, with a 59 modifier, D22.72. And option C, 11106, 11105, D22.72. Option D, 11104, and 11107 with a 59 modifier, D22.72. A 30-year-old female with two suspicious pigmented lesions on the left lower leg underwent a biopsy after discussing risk, benefits, and alternatives. Local anesthesia was administered and a timeout confirmed with the patient and operative site. A 4 punch biopsy was performed on the first lesion, while the second lesion was incised with number 4 blade. The samples were sent to the pathology and his hemostasis was achieved with electrocautery. The wounds were sutured and covered with sterile bandage. The procedure was well tolerated and the pathology result confirmed melanocytic nevi. Of the following answers, which best describe the procedure and coders? Okay, again, I will give you 2.5 minutes. Place your answers in the chat and all the best. Okay, Codus. I think yes, that is time, and I can see answers in the chat. Okay, so here we are going to have another great scenario. All right, so let me start explaining this one. So here we have diagnosis inventory, melanocytic nevi, and procedure inventory. We have two types of biopsy, two techniques of biopsy was used for the biopsy of two lesions, right? So you have first lesion that was biopsied using a punch biopsy, and the second was biopsied using an incisional biopsy. So there are two techniques or two types of biopsy performed, and we all know that when two different types of biopsies are performed, you have to code for them both, right? And option A, I can see on side. Option A is incorrect. If you know that guideline, you can eliminate option A on side, right? So this is an advantage. This is advantage of knowing or having strength on your uh, guidelines. So I know that I have to code for both of these biopsies. That means option A is incorrect. Yes, this is a guideline which states that you have to code for both biopsy. So option A is only coding for an incisional biopsy. 11106, that's only for an incisional biopsy. So that is incorrect. All right. Now I can see option D, that is coding for a punch biopsy of the skin. And again, I know that option D is also incorrect. How? Yes, I know the guideline that if multiple biopsy techniques were used for a same on the same session at two different sites, you have to first code according to the hierarchy. And the hierarchy states that you have to code the incisional biopsy first, followed by the punch, and followed by tangential, right? So we have a punch biopsy and incisional biopsy performed in this scenario. Okay, I can see a lot of people are changing the answers in the chat. So I know you all got the aha moment. So great. Okay, so the guideline states that you have to code the incisional biopsy first, and option D is coding for punch biopsy first. And that makes option D incorrect, right? So that is incorrect. Now between option B and C, again, that was a two options which had a major traffic. And yes, okay, so option B is incorrect one. All right. So although it's coding first for the incisional biopsy code, that is 11106, that is for incisional biopsy of the skin single lesion. The second code which is used, that is not an add-on code. That is for 11104. That is not an add-on code, right? Guidelines state that if if two or three different biopsy techniques were performed, you have to first code for the appropriate biopsy code. That would be 11102, 11104, or 11106, plus an additional add-on code must be used. And the add-on codes might be 11103, 11105, or 11107 for each additional biopsy performed. And in our scenario, it was a punch biopsy performed, and the code would be 11105, right? So you are not going to go to primary codes together. That makes option C the correct answer. Yes, so I saw a lot of people changing the answers. How are you all doing, coders? Let me know in the chat. If you had an aha moment, please let me know in the chat. Okay. And meanwhile, let's move on to the next scenario. All right. Exercise number 3, of the following answers which best describe the procedure. Option A, 11010. Option B, 11044. Option C, 11042. Option D, 11043. A 28-year-old male sustained an open fracture of the right ulna during a baseball game after falling on his outstretched arm. The wound was contaminated with grass and dirt, requiring surgical debridement in In the operating room, the surgeon removed debris and necrotic tissue, extending the debridement to 20 square centimeter down to the subcutaneous level. The wound was irrigated with sterile saline and left open for monitoring. Post-operatively, the patient tolerated the procedure well with no immediate complication and was scheduled for a follow-up care. Of the following answers, which best describe the procedure? And coders, your time begins now. All the best. Okay, Coda. So I'm going to stop the timer now because we got few more scenarios to cover. So, Coders, if you are still working on, please continue, or you can watch the playback as well. Okay. So I will continue with explaining the answer for this scenario. Okay, I can see a lot of answers in the chat. Okay, a lot of option A and a lot of option C's. Okay, so let's see which one is going to be the correct answer here. All right, so you must have seen the answer by this time. Uh, Here in our scenario, we have diagnosis inventory, open fracture of the right ulna, and a procedure inventory. We have surgical debridement. Now the question is, where was the surgical debridement performed? Let me know in the chat. Where was the surgical debridement performed in this scenario? Okay, great. Answers are changing once again. Great. You all are grasping the or taking the guidelines and changing the answer. So that's very good. Okay. So debridement in this scenario was performed at an open fracture. Yes, that was your site. We had an open fracture of the right ulna, and debridement was performed at the site of an open fracture. Right. Now, option D, that is coding for a debridement of a muscle and fascia. Option C is coding for a debridement or for subcutaneous tissue. And option B is coding for debridement at the bone or debridement of the bone. And option A is coding for a debridement including removal of the foreign body at the site of fracture and or open dislocation. And the level of debridement performed for option A, that is 11010, is till or including skin and subcutaneous tissue. And in our scenario, yes, the debridement was performed at the fracture on a fracture site at the fracture site, and oops, and the site and the level was also till the skin and subcutaneous, right? Yes, it was done down to the subcutaneous level. There you go. So the correct answer is going to be option A. So coders, be specific when you have a specific question. All right. The other ones are general debridement codes. So we had a specific scenario here for a debridement performed at the open fracture site. Okay. I hope the explanation helped. Please let me know in the chat. If you have any doubt, our team is in the chat. They are going to help you. Okay, so let me quickly move on to the next one. Exercise number 4. We've got 2 more to complete. Okay, of the following, which CPT code most appropriately describe the procedure performed? Option A, 11042 times 1, 11045 times 1. Option B, 11043 times 1, 11046 times 2. Option C, 11042 times 1, 11045 times 3, 11043 with a 59 modifier. 11042 times 1, 11045 times 2, 11043 with a 59 modifier. A 72-year-old diabetic male patient with the 3 chronic non-healing ulcers, first wound located on the left lower leg, measures 8 into 5 centimeter, that is 40 square centimeter, and extends into subcutaneous tissue. The second wound on the right heel measures 6 into 4 centimeter, that's a total of 24 square centimeter, and also involves the subcutaneous tissue. The third wound located on the uh, right ischial area measures 3 into 2 centimeter, that's 6 square centimeter, and extends into the muscle layer. The provider performed debridement of devitalized tissue for all the 3 wounds, and a total surface area debrided at subcutaneous level wound 1 and 2 is 64 square centimeter, and at a muscle level wound 3 is 6 square centimeter. All the debrided tissue is removed uh, down to the healthy viable tissue, and appropriate wound care instructions are provided. Of the following answers, which best describe the procedure? Okay, coders, so you have all the measurements over here, and I will give you, yes, 2 minutes to solve this one. Okay, and your time begins now. Okay, coders, I think you all are doing a fantastic job over here. Let me start explaining the procedure. Okay, so yes, so here we have in diagnosis inventory chronic non-healing ulcers. There were three ulcers, one on the left lower leg and one on the right heel. Both were at the subcutaneous level, so both were at the same level. And we know the guideline from the guideline that if a debridement is performed at the same depth, we can add those areas. Yes, so we had a 40 square centimeter and a 24 square centimeter of debridement performed at a subcutaneous level, so we can add those two areas, and that would give you a 64 square centimeter of debridement performed at a subcutaneous level. And for the right ischial area, the debridement was performed at a muscle level, and your measurements are 6 square centimeters. Okay, so let's keep that in mind. And option A is coding for 11042 and 11045. That is for a debridement of subcutaneous tissue. And option B is coding for 11043 and 11046. So that is for a debridement of muscle or fascia. So these codes are incorrect, because the reason why these are incorrect, because from the guidelines we know that if two biopsy or sorry two debridements are performed at two different level, we can have two levels in our answers. Okay, yes, the guideline is over here. If in multiple wounds, some the surface area for those wounds that are at same depth. So we already done that for the wound debrided at subcutaneous level, but do not combine the sum of different depths. So we are not going to combine the debridement done at a muscle level. We are going to code them separately. And option A and option B are incorrect, because they are only coding for a debridement performed at a one level only. Either option A is for debridement performed at the subcutaneous level, while option B is for debridement performed at a muscle level. So option A, option B, both are incorrect. We are left with option C and option D. So most of you were between this option C and option D, I guess. Okay, now let's do the mathematics. Okay, so we are going to code for a debridement at subcutaneous level, and we have a measurement of 64 square centimeter, and 11042 is for debridement of subcutaneous tissue for the first 20 square centimeter. So out of 64, the first 20 square centimeter is covered by 11042, and we have remaining 44 square centimeter. For that, we have to assign 11045, which is for each additional 20 square centimeter, uh, additional 20 square centimeter. So to cover 45 square centimeter, we need to multiply, or we need three quantities of 11045, right? And that makes option D incorrect. And we also have to code for ischial area debridement that was performed till muscle level for 6 square centimeters. And the answer for that would be 11043. So option D is incorrect, and the correct answer is going to be option C, 11042 and 11046 times 3 and 11043. All right, coders, how are you all doing? How are you all doing? So yes, we are coding them based on the depth. Okay, great. So let's move on. Let us know in the chat how are you all doing. Meanwhile, I'm going to the exercise number 5. Okay, of the following answers, which best describe the procedure? Option A, 11641. Option B, 14021. 11641. Option C, 14041. Option D, 14021. A patient presented with a 1 centimeter malignant lesion on her cheek. The lesion was surgically excised with clear margin Following excision, surgeon performed a 15 square centimeter C-plasty to repair the defect, improving both function and aesthetic appearance. Of the following, which best describe the procedure? All right, coders, your time begins now. Okay, coders, so keep the answers coming in the chat, and let's review this one. Let me walk you through this scenario. So here we have a patient with a malignant lesion on her cheek, excision and C-plasty repair was performed. Okay, so option 11640641, that is option A, is coding for excision of a malignant lesion, excised diameter zero point 0.6 centimeter to 1 centimeter. And the guidelines of ATT, or adjacent tissue transfer procedure, states that the excision of benign or malignant lesions are not separately reported with the adjacent transfer tissue transfer sorry, adjacent tissue transfer codes, right? Okay, so that means you cannot code excision procedure codes here. So option A is incorrect. Also, option B is incorrect. That is also coding for excision of lesion, malignant lesion code, right? So that is also incorrect. You cannot code excision procedures because that is included in the adjacent tissue transfer CPT codes. All right, now we are left with option C and D. Let's see what are they coding for. Okay, so here is where you have to be forensic. Option C is coding for 140. Sorry, option C is option D is coding for 14021. That is for adjacent tissue transfer of scalp, arms, or legs, and the defect size would be 10 zero point 0.1 square centimeter to 30 square centimeter. So why is option D incorrect here? Yes, option D is incorrect because that is coding for a wrong location. We had ATT performed on the cheek. Okay, So that is a keyword here. It's a Z plus T. That is your for your ATT procedure. So adjacent tissue transfer was performed on the cheek, and 14021 is coding for an ATT procedure at scalp, arms, and or legs. So that's a wrong location. That's why option D is incorrect. The correct answer is going to be 14041. That would be for adjacent tissue transfer at forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands, and feet. And the defect size would be 10.1 square centimeter to 30 square centimeter. So our defect size was 15 square centimeter. So that also covers in CPT code 14041. All right, so option C is the correct answer. Okay, Codus, quickly let me move on to the last question for the day. Of the following answers, which CPT code best describes the procedure? Options are option A, 14041 times 2, option B, 14041, option C, 14301, option D, 14301, 1512051 modifier. A patient presents with a 6 centimeter malignant lesion on the neck. The surgeon excises the lesion with a 0.5 centimeter margin, resulting in a 7 centimeter diameter surgical defect, that is 50 square centimeter. And to close the defect, a rotation flap from the adjacent neck tissue is performed, and the flap donor side is partially closed, leaving a 10 square centimeter secondary defect, which is covered with a split thickness graft. Of the following, which CPT code most appropriately describe the procedure? Okay, coders, quickly, I will give you around 1.5 to 2 minutes for this one. Okay, let's do it. All right. I can see the answers coming in the chat. Good job, excellent job. And here is how we arrive at the correct answer in this scenario. Okay, so we have a patient with malignant lesion on the neck, 6 centimeter, an excision and a rotation flap was performed here, right? Okay, so 14040 is coding for an adjacent tissue transfer of the forehead, cheeks, chin, mouth, neck, axilla, and genitalia, hands and or feet of defect size 10.1 square centimeter to 30 square centimeter. Now, my question would be, what is a defect size in this scenario? Coders, if you know, place them in the chat. What is going to be the defect size for this scenario? Let me know in the chat quickly. Okay, you can type it in the chat because I would say that is going to be 50 square centimeter plus 10 square centimeter. That would be 60 square centimeter. You are absolutely correct. Yes, absolutely correct. It's going to be 60 square centimeter. You know why? Yes, it's because of the guidelines. The guidelines states that for the purpose of code selection, the term defect include the primary and the secondary defect. And what is a primary defect? The primary defect is the defect that is resulting from the excision, right? And the secondary defect is the one which is resulting from the flap designed to perform the reconstruction, and these are measured together to determine the code. Yes, I can see a lot of people saying yes, it's 60 square centimeter. Okay, so here we go. We had a primary defect of 50 square centimeter, and you can see to close the defect, rotation flap from the adjacent neck tissue is performed. The flap donor side is partially closed, leaving an additional 10 square centimeter, and that is your secondary defect. Okay, so you have to add both of them for code determination, and that would be a 60 square centimeter. So that makes option B incorrect, right? And option C is coding for adjacent tissue transfer of any area 30.1 square centimeter to 60 square centimeter. Yes, so that is going to be your code, and not option A. Option A is coding for 14041 times 2. You don't need to bill for a second quantity of 14041 here. We have a code specifically that is coding for a 30 square centimeter to 60 square centimeter adjacent tissue transfer procedure, and that is going to be of 14301. Now between option C and option D is coding for a skin graft procedure. Yes, split thickness autograft, that is 15120. And option D, I would say option D is the correct answer, because again, the guideline states that skin graft necessary to close the secondary defect is considered as an additional procedure, and we have to code them as well. So option C is not coding for a skin graft procedure, and the correct answer is going to be option D, 14301 and 15120, the 51 modifier. Okay, Curtis. I can see a lot of people got this one correct. So, yes, you all were spot on with the guidelines in this scenario. Yes, excellent job, Curtis. So, that's all about the scenarios. Let me quickly go take you through the hand poll, the rapid fire scenario. So, I have few hand poll scenarios for you, only a few of them because we are almost time. And here we go. Let me know in the chat. Type your answers in the chat. Excision of malignant lesion following the adjacent tissue transfer for closure is reported as the following. Your options are option A, both excision and ATT. Option B, only excision code. Option C, only ATT code. Option D, either code depending on the payer policy. Which is the correct answer for this scenario? Okay, Curtis, this is rapid fire round. You have to answer them quickly. Okay, let me know in the chat. Okay. Mhm. Follow the guidelines. Follow your guidelines. Follow your CPT guidelines for the exam. Okay. Okay, great. Excellent. And yes, option C is the correct answer. Spot on. Everyone is spot on with this one. Next question. A biopsy performed as a part of another procedure, it can be excision, destruction, shave removal, is option A, reported separately with a biopsy code. Option B, included in the main procedure and not reported separately. Option C, reported with a modifier 59. Option D, always reported as 11106. That's your excision procedure code. Okay, okay. I'm not getting time to complete reading the answers. You all are so quick to place your answers in the chat. Okay, so follow the guidelines. Mhm. Okay, so here we are going to have an aha moment. Chorus, read the question once again. A biopsy performed as a part of another procedure. So that is done as a part of another procedure, right? And if it is performed as in another procedure, we can't code them. Yes, it is included in the main procedure and they are not reported separately. So a biopsy must be performed independent and distinct from the other procedure performed at the same session. That's what the guidelines said. right? So you cannot code them if it is a part of another procedure. Okay. Okay. I can see one option B in the chat. I think that was an aha moment. So good one, good learning moment. And here we go. Next scenario. When multiple wounds of the same depth are debrided, how is coding determined? Is it option A, report each wound separately? Option B, add the surface areas and report one code? Option C, use only deepest wound for coding? Option D, report the largest wound? What say you, coders? Yes. Okay, everyone are back. Yes, the correct answer is going to be option B. You have to add the surface area and report one code. So good one, good one. Good comeback, everyone. Excellent job. Okay, I think this is going to be the last hand pull scenario. Which of the following is an example for adjacent tissue transfer? Is it option A, Z plasty? Option B, simple closure? Option C, undermining only? Option D, direct sutures? Let me know in the chat. Okay, great. A lot of fastest fingers in the chat. Yes, great. You all got that one correct as well. It's a C plus D, right? I said in the beginning that was one of your keyword. Okay. All right, Corey. So if you enjoyed our video, don't forget, please smash that like button and subscribe to our channel, and also share it with someone who needs to see this. Okay, so if you know someone who's preparing for the exam or someone needs these topics, please share with them as well. And I have placed the survey link in the chat. Also, let us know how was this session, and really, did you really enjoy it? Thank you for joining with us. I know it was almost more than 1 hour. So thank you for joining with us and staying with us. Also participating in the chat. You all made this a fabulous session. Okay, coders. So we'll come back next week with another topic. Okay. So till then, stay safe, keep coding. Thank you, team. Thank you to my fabulous team who was there in the chat supporting and encouraging the coders. So, everyone, thank you, and see you all next week with another topic. Till then, stay safe and keep coding.